I'm Dr. Tunajin Afrin Khan from United Hospital. I'm really delighted to present my case here, and I'm grateful to Sky to give me the opportunity to present in front of this learned audience. My patient, Mr. L.R., 57-year-old hepatitis dyslipidemic patient, who admitted in our hospital with a diagnosis of non-stimulated MI with acute left ventricular failure. He gave history of repeated non-stimulated MI at the same year, in April and first week of June, and echocardiography revealed inferior and inferior lateral wall hypokinesia with fair LV ejection fraction. It was the ECG at the time of presentation. He was also a known case of prostatic carcinoma, and he was on hormone therapy, and he was suspected to have liver metastasis, and he was also a known case of CKD and benign enlargement of prostate. He underwent TARP on 27th May the same year, and histopathology was suggestive of well-differentiated infiltrating adenocarcinoma. MRI of the whole abdomen was suggestive of suspected liver metastasis, and he was advised for PET scan and dynamic CT scan of hepatobiliary system. CT-guided FNAC of the liver failed due to deep sea ablation. And his bone scan, serum testosterone level and PSH levels were all normal. He was continued on hormone therapy. And during his stay in hospital, he was diagnosed as a case of COVID pneumonia, which was suggested by HRCT test, though RT-PCR was negative, and he was treated accordingly. This is his HRCT, where the total severity score was 10. Investigation revealed rise of troponin I. And others were he was suffering from lymphopenia, high CRP, D-dimer levels, low hemoglobin, and raised serum creatinine. Serum creatinine was 2.8 at the time of presentation with eGFR less than 30. After stabilization, coronary angiogram was done uneventfully on 3rd July 2021. CAG was done by left femoral artery with borderline lesion at the proximal RCA. But upon engagement of our French catheter, we observed fall of blood pressure. Significant lesion at the OM, we can see here, and borderline lesion at the distal part of the leg vein and mid-LAD, and one significant stenosis in the peak diagonal. So how should we proceed? Angiographically, the left main lesion and the mid-LAD lesion was borderline, but still the RCA lesion seemed to be significant due to dampening of the blood pressure. And if we do PCI in the LAD, should we go only for the diagonal, or should we proceed with the LAD and diagonal PCI, or we should mend all the lesions in left main, diagonal, and LAD? Are the borderline lesions functionally important? We consider this because it was left main and mid-LAD. So we decided to do PCI in the RCA and DFR in left main to LAD. For RCA, we took JR, 6 French guide catheter. The lesion was dilated into 2 with the 15 balloon. And we put a drug-eluting stent, it was 2.75. And post-dilatation was done with 3 into 12 millimeter balloon. RCA seemed to be well revascularized. For left main to LAD lesion, we took HB 3.06 French guide catheter, and we took the TFR wire, took a short scene during proceeding the TFR wire to measure the length of the lesion. And if this was the TFR for the mid-LAD lesion, it was significant with significant PD by PA. And for left main lesion, it was also significant. We also did the FFR, which showed borderline significant, but still DFR was significant. We took BMW wire in the LED and another BMW wire in the diagonal, and pre-dilatation in the diagonal was down. After pre-dilatation, we observed dissection at the diagonal. We put the stent, drug-eluting stent in the diagonal. And slow flow observed at the upper branch of the diagonal. We did the post-dilatation with the same stent balloon. For LED pre-dilatation, we took a 2 mm balloon at the main for the mid LED. And we put 2.5 to 7.5 to 32 mm stent for mid LED. For left main to LED lesion, we took 3.5 mm drug-eluting stent. And post-dilatation was done with the 4 mm balloon.
Go for the slide over there. Audio visual.
We did the IBUS, as it was a left main lesion that remained. IBUS showed very good minimal luminal area after stenting in the left main and also in the LED. This is the final scene. During follow-up, the patient was doing okay with hormone therapy for his prostatic carcinoma, and his D-dimer level fell to lower level, and he was also put on anti-COVID medications during his hospital stay, and he had to continue the anti-COVID medication 4 to 6 weeks after his discharge. And follow-up echo also showed better ejection fraction with the no neo-regional wall motion abnormality. His physiology, he was doing functionally okay. So my take-home message is multiple comorbidities should be addressed properly while planning for cardiac invasive procedure. Obviously, our patient was a complicated one with multiple comorbidities. And follow-up blood pressure is a very significant indicator for especially when especially for ostial or proximal lesion. And we should proceed for PCI in these sort of lesions. And DFR and IBUS play important roles in decision making and optimization of the procedure. I acknowledge my teacher, Professor Afzal Rahman, in regard of this case. And thank you all.
Wonderful presentation. It's a great case. We are really running short of time, so we have literally 1 minute for discussion. Any opinion or comments from the panel?
So, Dr. Khan, a great presentation. Whenever I decide to use FFR or IBUS, I use pre-PCI as well. So FFR of the RCA could have been done in this patient, or DFR, because you already pulled out the FFR wire. You're already charging the patient for that. So might as well give nitroglycerin, and I'm not sure whether the right coronary artery lesion is significant or not. So if you're taking it out, use it. It's not going to be extra time. So any type of extra stenting maybe can be avoided. And number two, I don't think IBUS pre would have changed your because you chose a good size stent. Here, sometimes I see that they choose 2.5 millimeter stent in the proximal LAD, which is really not the right thing to do.
Thank you, Khan, for nice presentation. My question, you did FFR in diagonal? Is there necessary to put a stent? Which technique you adopted for the diagonal? Because after putting a stent, you lost a large branch. Diagonal arise, then divided into two. You saw the after putting a stent, but there is a still plaque in the stent. So which technique you can you avoid this stent? Already left main RCA is okay, but can we avoid? This is the fourth stent in this patient. Fourth.
For diagnosis?
Yeah, diagonal.
Yes, just after the dissection, we saw the dissection and we put the stent directly there, but after the stent deployment, we could see there was still TIMI2 flow there, and as the patient was really complicated one, and we were processing for PCI in left main to LAD, and we tried to lessen our radiation time and as well as our dye in this patient, so we didn't intervene further in the upper part of the diagonal branch. So, and also the patient was not symptomatic at that time, and the vitals were all stable, so we decided not to intervene further in that branch artery.
But FFR in diagonal?
Because diagonals was already significant, so we didn't do DFR in that.
So I have one question regarding the brilliant presentation in a so comorbid condition, being so many stent placement is really a difficult job and is done excellently. But to Dr. Ramesh, my question is if there is sequentially two lesions, in that case, how shall we estimate FFR or DFR?
Let's ask her. In tandem lesions, you said left main DFR is this much and LAD DFR is this much, 0.72 in LAD, left main you said 0.79. How did you come to that conclusion is the question, right?
Yes.
How did you come to a conclusion in tandem lesions that the DFR, how did you come to the conclusion that left main was significant?
Because we decided to PCI in the left main on the basis of the DFR result actually.
No, what I'm saying is the DFR wire position, where was it?
Okay, so the DFR wire position was just beyond the left main lesion. We did DFR at the 2 point. For mid LAD, we put the DFR beyond the mid LAD lesion, and for left main, we put the DFR area just beyond the left main. So we did DFR at the 2 points.
So it does not always correlate that it is significant. That's what it's a very tricky question what he's asking. So it's not a simple question. In tandem lesions, DFR is not going to say that left main is this much, LAD is this much. Whatever the tightest lesion, you fix it first and then you remeasure the DFR to get the second one.
That's it. In other words, we can do IVAS. In other words, we can do IVAS.
Or you can place the DFR for left main into the circumflex.
The lesion in the left main to DFR was approximately more than 20 millimeter apart, so we did it at the same time. The lesion in the mid LAD and the left main lesion. That was more than.
No, even if it is, so you cannot accurately assess DFR or FFR in two tandem lesions in the same. So you can't put a wire in the LAD. Say LAD DFR is 0.79, you pull it back a little bit and say DFR of the left main is this much. That is not accurate. That's
Great learning points. Thank you so much, Timothy. I think that was a great case. I wish we could continue the discussion. Thank you so much. So, for the sake of time, we will move forward to the next case. I would like to invite Dr. N. Shafiq to present his case.
So before we get just I have one question. Suppose there is a tandem lesion that can be fixed with single stent. In that circumstance, suppose one is tight would I fix it with a smaller stent or just predilate it, then I will do the FFR, then I will fix both of them by a single stent. Understand? Two lesions very close to each other. Just tightest on, I will predilate. Then I will do the FFR or FFR. Then if it is significant proximal one, then two lesions will be covered by a single stent. Is it? Why is that? Just I will put the stent to the distal one, then I will.
So if you predilate and if your DFR is 0.89 and above, we don't know what to do with that, right? If you predilate and the DFR is normal, or at least normal.
Predilate single one, other one shows